All right. So I think we are live. Hello and good evening to everyone. Can you please let me know in the chat box if my audio is good and also the video? Please let me know. Right. So I think we'll start. So this is part 2 of the recall questions of medicine system-wise of NEET PG 2024. So let's get started. Okay. Right. So this is the QR code of my Instagram page. So in case you want to follow this for academic updates, you can just follow this. Okay, right. So today we'll be discussing the 3 important systems, that is hematology, endocrinology, and rheumatology questions that came for the NEET PG 2024. So I hope all of you are ready. Yes. Right. Let's go to the questions quickly. First, we'll see the set of endocrinology questions. So remember, this time for 2024 NEET PG, we had 2 sets. Exam was conducted in 2 sets. So whatever I'm discussing will be from both the sets combined. Okay. So let's go to this question, a relatively simple one. A 45-year-old male presents with enlarged sweaty hands, macroglossia, frontal bossing, and increase in shoe size, and construction of previously well-fitting rings. Which is the most appropriate initial test is the question. So what do you think? So as you can see here, the clinical features of these patient, okay, that is mentioned, consisting of enlarged sweaty hands, macroglossia, frontal bossing. So all this is suggestive of what? Acromegaly, right? And what is the question? Which is the most appropriate initial test for acromegaly? So what do you think is the answer for this question? So I have already taught you in my lectures. For suspected acromegaly, the initial screening test is the serum levels of IGF-1, insulin-like growth factor 1, and the levels will be elevated. And what is the confirmatory test? The confirmatory test is the 75 gram oral glucose, 75 gram oral glucose growth hormone suppression test. After giving 75 gram oral glucose, what you expect is that this glucose in a normal individual should suppress growth hormone. Okay, so if after giving 75 gram glucose, you measure the growth hormone levels at 30 minutes, 60 minutes, 90 minutes, and 120 minutes. If in any one of these 4 values, it is less than 0.4 nanogram per ml, this will exclude acromegaly. Very, very important point. Any one of them. So what happens is that in case of acromegaly, it will not be suppressible. Even if you give the oral glucose, the value will still be above 0.4 nanogram per ml, right? Now, for this, what is the answer? Plasma GHRH? No, that's not going to be my answer. Age and sex matched serum IGF-1 levels? Yes, that is going to be my answer. Because IGF-1 levels, when you actually look at the normal value, it has to be age and sex matched. And what about option C, random serum growth hormone measurement? Wrong option. Why? Because the growth hormone normally is secreted in a pulsatile manner. So in the screening of acromegaly, there is no role for random serum growth hormone measurement. Then the last option, that is serum growth hormone level 2 hours after a 75 gram oral glucose tolerance test. Well, we are talking about the confirmatory test. They are asking about the initial test in this particular question, not the confirmatory test. So I'm ruling out this option as well. The correct answer is going to be option B. That is the initial test. Please look at the question carefully, right? Let's go to the next question. Which of the following growth hormone related agents is not used for treating growth hormone deficiency but is approved for managing HIV associated lipodystrophy? Very, very important point. has been asked here. Now, look at the options: tisamorelin, octreotide, somatotropin, and pegvisomant. So if you look at option A, tisamorelin, this is a synthetic growth hormone releasing hormone analog. Octreotide is a somatostatin analog, and somatotropin is a recombinant human growth hormone, and pegvisomant is a growth hormone receptor antagonist. These are the options that have been mentioned. So out of the options that have been mentioned, the growth hormone related agent, okay, which is primarily not used for treating a growth hormone deficiency, but is used for HIV associated lipodystrophy, is option A, that is tisamorelin. So what happens is that this tisamorelin can increase the levels of IGF-1. This can increase the levels of IGF-1, which will lead on to lipolysis. There will be lipolysis, and hence it is useful for HIV associated lipodystrophy. It will help in burning the fat. Okay, so that is option A as the right answer. So I can see most of you in the comment section have also correctly identified the answer. Let's go to the next question. A 50-year-old man presents with headache, palpitations, hypertension. So important combination: headache, palpitation, hypertension. So already I am thinking of a possibility of pheochromocytoma, seeing the manifestations. Going to the investigations, you can see that there is elevated urinary catecholamines and vanillyl mandelic acid. So what is vanillyl mandelic acid? It is a metabolite of the catecholamine. So the urinary levels are elevated. The imaging reveals an adrenal mass which is subsequently resected, and the histopathology of the mass is shown as in image. Which of the following is true about this condition? Well, the clinical picture is that of pheochromocytoma, and let us see if the histopathology is again correlating with the history and investigation findings. So what are you seeing? You can very well appreciate nest of cells. Are you able to very well appreciate cell nest? And what do you call these cell nest consisting of spindle cells? What do you call this cell nest? It is called cell belen. Yes, that is what is seen. So you are able to very well appreciate these cell nest, and these cell nest are often surrounded by certain sustentacular cells, and also you will have between the adjacent cell nest a fibrovascular stroma as well. So that is what you are seeing, and yes, histopathology is also correlating with pheochromocytoma. And what is the question? Which of the following statements is true about this condition, which means true about pheochromocytoma? What do you think about option A? Commonly associated with men to A. Is it a true statement? It is an absolutely true statement, because men to A, which is also known as Sippel syndrome, is very well associated with pheochromocytoma. Very well associated with pheochromocytoma. Usually bilateral is wrong, because 10% of cases are bilateral. Primarily affects children is again a wrong statement. Only 10% affects children. Most cases are malignant, again a wrong statement. Only 10% cases are malignant. So the true statement here is about option A. So I can see most of you have correctly identified the correct answer. Okay, let's go to the next question. A 25-year-old male presents with fatigue and generalized weakness. Now tell me about the presenting symptom. Is it specific or non-specific? Relatively non-specific symptom of fatigue and generalized weakness. Does not give me much information. Now coming to the examination, it shows a BP of 80/60, which means the patient is having hypotension, and then hyperpigmentation over the knuckles, palmar creases, and perioral region. Well, hyperpigmentation in relation to medicine can occur in multiple conditions like Addison's disease, hemochromatosis, vitamin B12 deficiency. But when you have a hyperpigmentation in the context of a low BP, you will definitely suspect a primary adrenal insufficiency, which may even land up in an adrenal crisis, right? And let us see the laboratory evaluation and see if it is again correlating with the adrenal insufficiency. So the laboratory evaluation shows a sodium level of 127, which means the patient is having hyponatremia, and the potassium levels are slightly elevated, showing there is some degree of hyperkalemia as well. So when you get this combination of relatively non-specific symptoms like fatigue, generalized weakness, along with hypotension, hyponatremia, hyperkalemia, with the pigmentation, what are you thinking about? Primary adrenal insufficiency is without any doubt the answer, right? What about Conn syndrome? They'll be having hypertension with hypokalemia, definitely not the answer. What about vitamin B12 deficiency? Can produce hyperpigmentation, but none of the other manifestations like hypopigmentation and the electrolyte abnormalities mentioned, it is not going to correlate. SIADH can produce hyponatremia, but none of the other features occur in this. So clearly the answer is going to be option B. Clear? Right. Let us go to the next question. What defines stage 3 beta cell destruction in type 1 diabetes mellitus? So in my routine lectures, I have stressed the etiopathogenesis of type 1 diabetes as well as the various stages of evolution of type 1 diabetes. I have shown you in my lectures a similar diagram that is on the stages of the type 1 diabetes, stage 1, stage 2 and stage 3. The question is about stage 3. Well, in all these three stages, the patient will be having evidence of beta cell autoimmunity with the presence of the autoantibodies, no doubt about it. In all of them, there will be beta cell loss, but again, as the stage goes from 1 to 3, there will be more profound beta cell loss. Now comes the important part. What about the dysglycemia? In stage 1, there is no dysglycemia. In stage 2 and stage 3, there is dysglycemia. That means there is hyperglycemia. And watch out, symptoms. Symptoms are absent in both stage 1 and stage 2, but the symptoms are present in stage 3. Now, coming to the question, what defines stage 3? It is autoimmunity positive, dysglycemic, as well as the patient is symptomatic. Option B is the correct answer. Let us go to the next question. 26-year-old woman at 8 weeks of gestation. Very, very important point here in the question is about the 8 weeks of gestation, which means first trimester, which means the first trimester. So the patient has been newly diagnosed with hyperthyroidism. What is the most appropriate initial treatment? What do you think? First trimester, what is the drug that has to be given? No doubt about it, propyl thiouracil. And maybe in the second and third trimester, you may consider switching back to methimazole or carbimazole. But in first trimester, there is no doubt it is PTU, right? Let us go to the next question. 30-year-old woman presents with unexplained weight loss, persistent tachycardia, heat intolerance, and fine tremors. On physical examination, she is found to have exophthalmos. What is the most likely diagnosis? I don't think you can get more even simple question. The answer is going to be Graves' disease. Okay, none of them, even come close to the right answer here. Okay, so there were quite a few questions asked from the topic of thyroid. I think most of them were relatively easy. Okay, the two sets combined, the set 1 in the morning session, set 2 in the afternoon session. Let me just take you through the questions. Another very simple question. A 35-year-old woman presents with a solitary palpable thyroid nodule at the front of her neck but without other symptoms. The most appropriate initial investigation in managing the patient has been asked. Look, when a patient comes with such a nodule, you just think in routine practice, what are you going to do? The first test that you are going to do, is it going to be FNAC, thyroid scan, biopsy? No, it is first going to be thyroid function test. Use your simple clinical knowledge and logic, right? Okay. Next question, choose the false statement about thyroid eye disease. Okay, you have to choose the false statement. No specs classification is used. It is true. So that is not going to be the answer. May lead to visual loss, which is also true, eliminating that option. Improvement of symptoms corresponds to the improvement in thyrotoxic state. Well, this is not a true statement, because even if the thyrotoxic state comes under control, the thyroid eye disease may not be controlled, because you will need an additional treatment with drugs like systemic steroids. So the answer for this question is going to be option C, but I just want to look at option D as well. 10% of patients are euthyroid. Do you think this is correct or not? It is correct. It is correct. 10% of patients with thyroid eye disease may be euthyroid. Yes, it is a true statement. So the answer for this question is going to be option C. Coming to the next question, examine the histopathology image of the thyroid lesion provided. Which of the following genetic mutations is most commonly associated with this type of thyroid carcinoma? Well, again, a very simple question. The image was showing the the orphan Annie nuclei with the clear cytoplasm, and what is the most common gene mutation associated? The BRAF V600E mutation is associated. Answer is going to be option C. Coming to the next question, a 65-year-old woman presents following a hip fracture. She has a history of multiple fractures, and her DEXA scan shows a T-score of -2.7. Which of the following serum biomarkers would most likely be elevated in her laboratory profile? Is it AST, ALT, LDH, or TRAP? What do you think is the answer for this question? Dr. Pratusha, Dr. Nafrin, Archana, Sharon, Kamal, can you just come up with the answer? First of all, let us try to analyze the data that is given in question. The patient has a T-score of 2.7. So what is your knowledge about T-score? We know that the T-score is expressing the bone mineral density as the number of standard deviation from the young sex-matched means in comparison to the Z-score, which is both age and sex-matched. When a patient has a T-score more than or equal to -1, it is normal. When the patient has the score in -1 to -2.5, it is osteopenia. Less than -2.5 is osteoporosis, and less than -2.5 with a fracture is severe osteoporosis. So my dear children, in the comment section, can you tell me what disease state is our patient suffering from? Already the T-score has been mentioned, and there is history of hip fracture. So the patient is having severe osteoporosis. Now, you look at the options. We know about the markers of bone formation. We know about the markers of bone resorption. In this particular patient, what do you think? Will it be osteoclastic or osteoblastic activity that will be predominant? Definitely the osteoclastic activity, right or wrong? Yes, right. So when the osteoclastic activity is predominant, you will definitely have elevation of markers of bone resorption, correct or not? And among the options that are given below, which is the marker of bone resorption? The answer is going to be option D, that is tartrate resistant acid phosphatase, right? Okay, let us come to the next question. Which of the following? So now we are moving on to the hematology questions that were asked in NEET PG 2024 from both the sets. Which of the following is the best test to evaluate the intrinsic coagulation pathway, more reliable than directly measuring the individual clotting factors? Very, very simple question. It is the activated partial thromboplastin time, whereas the prothrombin time is for the extrinsic pathway. So the extrinsic pathway as well as the common pathway is by the prothrombin time. The intrinsic pathway as well as the common pathway is by the activated partial thromboplastin time, right? So this is again a simple diagrammatic representation of the clotting cascade, and you can see here the intrinsic pathway. The assay that is commonly used is the activated partial thromboplastin time, right? Okay, let us go to the next question. A 30-year-old man presents with chronic diarrhea since childhood. Watch out, chronic diarrhea since childhood. Then there are certain visual disturbances and a recent onset ataxia. So there is a chronic diarrhea, some visual disturbances, and of late he has developed ataxia or unsteadiness of gait. His peripheral smear is shown below. Based on the findings, which diagnosis is most likely? So what do you think is the peripheral smear finding, and how can you correlate the clinical history with the peripheral smear finding? So can you notice certain abnormal cells out here? Are you able to notice certain abnormal cells out here? So can you tell me what are these abnormal cells? Let me just give you two diagrams or two peripheral smears for comparison. Now in the image 1, you are definitely able to see certain cells which are having certain irregular projections, right? Okay, in the surface. And these RBCs are lacking central pallor, correct or not? Along with that, in the next figure again, you can see that again the RBCs are there which are having certain very blunt, you can see they're very small, you'll have to notice it very carefully, very blunt small projections you can see on the surface of RBCs. So can you tell me what is this comparison? What is 1, what is 2? My dear children, you please understand that when you talk about spiculated RBCs, there are two type of spiculated RBCs. Number 1, the acanthocytes, which are also known as the spur cells, as well as the echinocytes, which are also known as the Burr cells. In case of acanthocytes, you will have unevenly spaced, irregular, pointed or club-like projections. They're very irregular on the surface of RBCs, as well as the acanthocytes will be lacking central pallor. And in what condition are acanthocytes seen? In case of liver disease, in case of A beta lipoproteinemia, as well as in case of neuroacanthocytosis. Very, very important. Now, coming to the next entity, which is echinocytes or Burr cells. How are they different from acanthocytes? Here, you will have evenly spaced, uniform, short, blunt projections on the surface of RBCs. They are commonly associated with uremia, then maybe as a part of artifact during peripheral smear preparation, sometimes as a part of prolonged blood storage. When the specimen is stored for some time and then you make a smear, there is chance of these apparent echinocytes. Sometimes in case of burns and even in case of pyruvate kinase, that is RBC glycolytic enzyme defects, that can also result in echinocytes. So we have understood the causes of acanthocytes and echinocytes. Now, if you look at this particular condition, having certain GI symptoms, ocular symptoms, and now neurological symptoms with acanthocytes, what are you probably thinking about? Because in the peripheral smear, it is clearly the acanthocytes. These are irregular projections on the surface of RBCs and they do not have a central pallor. And we are probably talking about this particular disease, that is A beta lipoproteinemia. And this A beta lipoproteinemia, let us look at some very important MCQ points regarding this. It is also known as Basen-Consweig syndrome. It is a disorder of lipoprotein metabolism. Very important pattern of inheritance is autosomal recessive. The gene mutation is MTTP gene mutation, which is the microsomal triglyceride transfer protein, which transfers lipids to chylomicrons, and ultimately what happens is there is a defective formation of chylomicrons. Very important. Okay, so this is what happens in A beta lipoproteinemia, but my children should know that this is a systemic disease. You can have multi-system manifestations. In case of childhood, that is the childhood presentation will be with failure to thrive, and the patient will have diarrhea resulting in loss of fat, that is steatorrhea will be there. There is fat malabsorption, steatorrhea will be there. And that is what happens in the initial presentation. In the 3rd to 4th decade, the patient starts to develop neurological manifestations like ataxia, spastic gait, and many other neurological manifestations are there. And also the patient may get ocular manifestations in the form of retinitis pigmentosa. Now come back to the scenario. We have got this patient with a chronic diarrhea since childhood. Can it happen in A beta lipoproteinemia? Possible. Can you have visual disturbances? Possible. Retinitis pigmentosa. Can you have recent onset ataxia? Again, possible. So what do you think is the most likely diagnosis for this particular condition? The answer is going to be A beta lipoproteinemia. Is it clear for all of you? Yes, let us go to the next question. Okay, right. So next question. A child presents with fragile hair and depigmentation of skin. Laboratory evaluation shows anemia and neutropenia. Which nutrient deficiency is most likely responsible? Is it copper, fluoride, iron, zinc? What do you think? Well, it is a factual question. It is copper. My students, you should know the important manifestations of copper deficiency. Number one, coming to the neurological manifestations, it can result in spinal cord involvement, resulting in a myelopathy. And what sort of spinal cord involvement? It is usually a subacute combined degeneration of the spinal cord, which is very similar to that of vitamin B12 deficiency. So please understand another potential MCQ, which nutrient deficiency can produce a subacute combined degeneration very similar to that of vitamin B12 deficiency. It is copper deficiency. It is also referred to as a hypocupric myelopathy. It can also result in a neuropathy. Hematological manifestations include anemia, neutropenia, and very rarely pancytopenia as well. The other manifestations include a fragile hair, skin depigmentation, growth retardation, and osteoporosis. So if you look at the question, yes, fragile hair is there, depigmentation of skin, and anemia, neutropenia. This combination of features can occur in case of copper deficiency. What about the other options? Zinc deficiency. Well, it can produce failure to thrive in infancy and in adults, growth retardation, alopecia, dermatitis, diarrhea, decreased taste and smell sensation, immune dysfunction, as well as gonadal atrophy. These are the manifestations of zinc deficiency. And can you tell me what is that inherited disorder affecting zinc absorption? It is called ectodermatitis enteropathica. I'm sure you would have heard about this as well. It is also a potential question. Ectodermatitis enteropathica. And fluoride deficiency can cause an increased risk of dental caries. That is what? Okay, that is what. So let me just come back to this question. My dear children, are you having any doubts regarding this? Can you give me a thumbs up if I can go to the next question, please? Yes. Can I go to the next question? Which of the following statements about von Willebrand disease is incorrect? Incorrect. So basically the question is asking about the different types of von Willebrand disease. My dear children, in my lectures, I have taught you about type 1 von Willebrand disease, type 2 von Willebrand disease, and type 3 von Willebrand disease. And what did I tell you? Out of these three types, which are the quantitative defect? 1 as well as 2. These are the quantitative defect in von Willebrand factor. Whereas in case of the next one, number 2, it is a qualitative defect. 1 and 3, quantitative defect in von Willebrand factor. 2 is a qualitative defect in von Willebrand factor. So what is the first option telling you? Type 1 von Willebrand disease presents as a very severe disease in children. It is wrong. When you compare type 1 and type 3, please understand type 3 is the more severe one, because though both of them are quantitative defects, one is a mild quantitative defect and 3 is a severe quantitative defect. So the first option, it is factually wrong, but they are asking about the incorrect statement. So this has to be my answer. Meanwhile, let me go through the remaining options. Type 2 von Willebrand disease typically leads to a moderate bleeding tendency. That is true, because the one that leads to a severe bleeding tendency is 3. Mild is 1 and 2 is moderate. Type 2 is due to a qualitative defect is also a true statement. Type 3 von Willebrand disease will have profoundly reduced levels of von Willebrand factor is also a true statement. So my answer is going to be option A for this particular question, right? Okay. Coming to the next question, a very simple one. A 25-year-old female with thalassemia major receiving repeated blood transfusions presents with sudden worsening anemia. Okay, so the patient is having a background history of a hemolytic disorder like thalassemia. And what is the patient presenting with now? Sudden worsening anemia. The laboratory findings are suggesting an aplastic crisis. So they've already said that this patient is having an aplastic crisis. And what is the question? Which of these infectious agents is the most likely cause of this clinical deterioration? So remember, when a patient with a hemolytic disorder like thalassemia, sickle, hereditary spherocytosis has sudden worsening of anemia, there could be a possibility of an aplastic crisis. And what is the most common agent? It is parvovirus B19. That is going to be my answer. Coming to the next question, 35-year-old woman presents with fatigue, lethargy, and heavy menstrual bleeding. Okay, the laboratory studies are showing the hemoglobin value of 7.9. So definitely there is anemia. MCV is low. So in the background of a heavy menstrual bleeding, I'm already considering an iron deficiency anemia. Let me see whether the other points are favoring. MCH is low. TIBC is elevated. Yes, as in case of iron deficiency anemia. Transferrin saturation is low. Peripheral smear shows microcytic hypochromic RBCs. Can it get even more simpler? No, it is very, very simple, right? So I can see most of you are answering correctly. Deepanshu, I can see Pratyusha, all of you are answering it correctly as iron deficiency anemia. In fact, in NEET PG 2024, there were 3 questions related to iron metabolism and iron deficiency anemia. This is the first one. Let us go to the next one. 28-year-old pregnant female presents with generalized fatigue. So what could be the reason for the fatigue? Let us see. The peripheral smear is showing microcytic hypochromic anemia. So probably another iron deficiency anemia here. Let us see the laboratory findings as well. Low serum iron, okay, elevated RDW, low MCV, low MCH, increased total iron binding capacity. What would you expect her percentage iron, percentage transferrin saturation to be? So what is the formula of percentage transferrin saturation? Serum iron divided by TIBC into 100. In case of iron deficiency anemia, serum iron is reduced, TIBC is elevated, hence the level is going to be reduced. So the answer is going to be option B, right? Okay. So let us go to the next question. Which of the following statements about iron metabolism is incorrect? Incorrect statement. So the first option is iron is transported in the bloodstream by binding to apoferritin is the first option. Serum ferritin reflects the body's total iron stores. Next one, within the cells, iron is stored as ferritin. And the last option, free bracket unbound iron is toxic to cells. So what do you think, my dear students? What is going to be the answer for this question? The first one is a wrong statement, my dear students. So they're asking about incorrect statement. I've already got my answer. So iron is transported not by apoferritin but by transferrin. Right? And what about the other options? The serum iron reflects the total body's iron stores. True. Iron stored as ferritin, option C. True. Free or unbound iron is toxic to cells. That is also true. So the answer is going to be option A. Next question. Which of the following statements about paroxysmal nocturnal hemoglobinuria is true? PNH, what is true? The first option, it is an inherited disorder. What do you think? Is it a true statement or a false statement? It is a false statement. It is not an inherited disorder. It is an acquired disorder. Next, the sucrose lysis test is diagnostic. Well, it can be used as a screening test, but never as the diagnostic test. Again, wrong. The most common cause of mortality is anemia and heart failure, which is again wrong. The most common cause of mortality is going to be thrombosis, maybe due to an event, a vascular event like a Budd-Chiari syndrome could be the cause of mortality. And the last option, flow cytometry, is the gold standard for the diagnosis, is absolutely true statement. So just summarizing some important MCQ points about paroxysmal nocturnal hemoglobinuria. It is an acquired hematopoietic stem cell disorder. The etiopathogenesis, it is an acquired mutation in the PIGA gene where the mutated RBCs will lack the CD55 and 59. Not only RBCs, other cells also may lack these, these cluster differentiating factors. And because it is absent on the surface of RBCs, the RBCs become susceptible to lysis by complement, resulting in the characteristic triad of intravascular hemolysis, pancytopenia, as well as thrombosis. This is the characteristic triad. Investigation for screening, you can use tests like Ham's test, sucrose test, but for the confirmation, it is going to be flow cytometry. Treatment, hematopoietic stem cell transplantation, as well as drugs like eculizumab and the newer drug that is ravulizumab. So eculizumab and ravulizumab can be used in the treatment. Let us go to the next question. A 12-year-old child presents with cervical lymphadenopathy. Immunophenotyping reveals positivity for CD10, 19, and 20, but negative for CD3 and TDT. Based on the histopathologic appearance and immunophenotype, what is the most likely diagnosis? Now, even before I look at the image, let me first analyze. So already it is given that it is negative for TDT. I'm already eliminating ALL. Correct or not? I'm already eliminating ALL. Now, looking at the others, you can see it is CD10 positive. So we know that mantle is CD10 negative. I'm already eliminating that. Now, coming to the image, you look at this, you can very well see that there are vacuolations. Can you see these vacuoles? Can you see these cytoplasmic vacuoles in these patients? Yes. So remember, in case of Burkitt's lymphoma, when you have this high power view, you can see these cytoplasmic vacuoles. And in the low power view, you can also see the starry sky pattern. From the recall that I got from the students, most of them told me they actually showed these cytoplasmic vacuoles. So that means it is suggestive of Burkitt's lymphoma. And not just that, the age of the patient is 12-year-old. So it is not the age group of a diffuse large B-cell lymphoma. My answer here is going to be Burkitt's lymphoma, considering the clinical history, immunophenotyping markers, as well as the histopathologic appearance. Okay, right. So let us go to the next question. A 34-year-old woman presents with fatigue, recurrent infections, and gum bleed. Laboratory shows a hemoglobin of 8. So there is anemia. Then there is leukocytosis, a WBC count of 1 lakh, and also thrombocytopenia. Okay, and let me look at the the peripheral smear. I can see promyelocytes. I can very well see the promyelocytes. I can see a prominent cytoplasm, and in the cytoplasm, some of them showing granules, and in some of them I can very well show you. I can, with this green arrow, I'm able to show you the presence of OR rods as well. Are you able to see some of the granules coalescing to form the OR rods? So basically the peripheral smear showed promyelocytes with OR rods. Now, to substantiate further, it was also given that PT and APTT was prolonged. Probably it is a setting of DIC. And when you have such sort of a leukocytosis, promyelocytes with OR rods and a coexistent DIC, I am thinking of an AML M3, which is an acute promyelocytic leukemia, right? So the question is, which chromosomal fusion gene is most commonly involved? What is it? It is the PML RARA fusion gene associated with AML M3. Very important question. Okay, right. So let us go to the next question. A 60-year-old man presents with fatigue, early satiety, and dull abdominal pain. Okay. On examination, he has an enlarged spleen. Okay. He has an enlarged spleen extending below the umbilicus. That tells me it is not any type of splenomegaly, it is a massive splenomegaly. It is not any type of splenomegaly, it is a massive splenomegaly. Right, children? It is a massive splenomegaly. And the laboratory studies are showing a hemoglobin of 10.5, a WBC count of 68,000, so it is increased, and platelet count of 4 lakh. Now, when you have a 60-year-old male, look at the age and look at the manifestations. Some vague manifestations with abdominal pain with a massive splenomegaly and leukocytosis. I am thinking of chronic myeloid leukemia. So what is the genetic abnormality? 922 BCR ABL. 922 BCR ABL is the answer. Okay, that is a very simple question. Let's go to the next one. A 30-year-old female presented with fever, night sweats, and 10% weight loss over the past 3 months. Physical examination reveals cervical and axillary lymphadenopathy. So the age of the patient, 30 years. Okay. And there are certain constitutional symptoms upfront for the last 3 months and some lymphadenopathy. An excisional lymph node biopsy was done. The histopathology slide is shown. So what is the finding? Very well appreciated RS cells, Reed-Sternberg cells. So the classic Reed-Sternberg cell could be very well appreciated. Now, can we come to a conclusion that this is probably a Hodgkin's lymphoma? Yes, the patient is having the B symptoms with the lymphadenopathy as well with the classic Reed-Sternberg cells. We know that Hodgkin's lymphoma patient has bimodal age group. In one set, it is usually 20 to 30 years. In that particular age group also, you can have Hodgkin's lymphoma. And another set of age group is above 50 years. Patients usually presents with asymptomatic lymphadenopathy, which may be involving the cervical, supraclavicular, mediastinal, retroperitoneal, axillary or inguinal nodes. And 40% of the patients may have B symptoms. Okay, I've just told you what these B symptoms are. That is fever, night sweats, as well as weight loss. Patients may also have hepatosplenomegaly. So I'm coming to a diagnosis of Hodgkin's lymphoma, which means I can already eliminate 3 options here. I've got the answer. Even if I don't know about what is the chemotherapy regimen, I have already got the correct answer. But again, coming to the treatment, you've got the classic Hodgkin's lymphoma as well as the nodular lymphocyte predominant Hodgkin's lymphoma. So when you look at the classic Hodgkin's lymphoma, it is managed based on the stage. The chemotherapy regimen is the ABVD consisting of adriamycin, bleomycin, vinblastine and dacarbazine. In this stages 1 and 2, I'm sure you already have basic knowledge of the stage 1 and 2. In stage 1, it's basically a localized disease with a single lymph node region or a single organ being involved. In stage 2, it is 2 or more lymph node region but on the same side of the diaphragm. In the image that you are seeing on the screen, the group of lymph nodes involved, both of them are above the diaphragm. Stage 3, 2 or more lymph node regions are getting involved but above and below the diaphragm. You can very well see above the diaphragm, below the diaphragm. And stage 4 is a more widespread disease with multiple organs being involved with or without lymph node involvement, right? So in stage 1 and 2, when you look at it, you can again subdivide into a favorable prognosis group as well as an unfavorable prognosis group. So what are the favorable prognostic markers? You need not know at your level right now. It is mainly a PG level topic, but again, so favorable prognosis group ABVD regimen, 2 cycles followed by the involved site radiation therapy. Whereas unfavorable prognosis group, you will require 4 cycles of ABVD regimen followed by involved site radiation therapy. In the advanced stages, stage 3 and stage 4, you will require 6 cycles of the ABVD regimen. And in cases of relapse, you will go for high dose chemotherapy as well as hematopoietic stem cell transplantation, right? Okay. Whereas the second group, the NLPHL, here the ABVD regimen will not work. Okay, the nodular lymphocyte predominant Hodgkin's lymphoma is managed similar to that of non-Hodgkin's lymphoma with the R-CHOP regimen being given. So 6 cycles of R-CHOP regimen, that is R for rituximab, then cyclophosphamide, doxorubicin, vincristine and prednisone. That is what is being given. So if you look at this, yes, the answer is going to be option A, Hodgkin's lymphoma ABBD chemotherapy regimen, right? Let us go to the next question. 60-year-old alcoholic male with a history of diabetes mellitus presents with polyuria, unintentional weight loss and tingling sensations in his lower legs. A bone marrow study has been performed. Based on the marrow findings and the clinical presentation, what is the most likely diagnosis? The options are vitamin B12 deficiency, diabetic neuropathy, multiple myeloma and alcohol-related neuropathy. Well, what is actually shown in this bone marrow study, you can very well see the malignant plasma cells. How did I understand these are malignant plasma cells? I can very well see the eccentric location of nuclei and the basophilic cytoplasm. So these are all the characteristics of the malignant plasma cells. That is what I'm seeing. Now look at the options. Vitamin B12 deficiency. Well, you can see here the patient is having some sort of tingling sensation, which means there is neuropathy. Okay, neuropathy. But is it a vitamin B12 deficiency neuropathy? I am not going to see any sort of other features like plasma cells in vitamin B12 deficiency. No, that is not going to happen. Diabetic neuropathy. Now you might think some students, thought, sir, this polyuria is there. Could this be due to diabetic neuropathy? Well, diabetes can cause polyuria, but what about the imaging findings or what about the bone marrow finding of the plasma cells? That cannot be explained by the diabetes. So though you have got diabetes which can cause polyuria and tingling sensation, the bone marrow study is not suggestive. So I'm eliminating that. What about multiple myeloma? Yes, plasma cells. It could be multiple myeloma. Now you will ask me, sir, why a weight loss? Well, it is a malignancy. You can have weight loss. Sir, why polyuria in multiple myeloma? Multiple myeloma can result in hypercalcemia. Multiple myeloma can result in hypercalcemia, and this hypercalcemia can result in polyuria. Right? Sir, can there be tingling sensation in multiple myeloma? Possible. In multiple myeloma, you can have neuropathy. What could be the reason for neuropathy? 3 important reasons. Number 1, the hyperviscosity itself can lead on to neuropathy. Number 2, as a part of cryoglobulinemia, you can have neuropathy. Number 3, due to the amyloidosis that can develop in patients with multiple myeloma. So the answer for this question is option C. Even alcohol-related neuropathy cannot have these plasma cells in the bone marrow study. Right? Right. Okay, let us come to the next question. A 50-year-old woman complains of fatigue and swelling in her limbs and enlargement of liver and spleen. Laboratory tests show anemia, serum creatinine of 3.2 and bone marrow biopsy reveals what? Reveals 22% plasma cells. Okay, with some eosinophilic acellular deposits. What is the associated pathology most likely? What do you think? Well, could this be MGUS? No, I am not going for MGUS because the patient is having 22% plasma cells. So it has got to be a multiple myeloma. So it is not MGUS. Fibrinoid necrosis, no, that is, we are not talking about any vasculitis or so. So it is not going to be a fibrinoid necrosis. What about amyloidosis? Possible, because in patients with multiple myeloma, can you have, an enlargement of liver and spleen because of amyloidosis? Yes, because in case of multiple myeloma, you can have the AL type of amyloidosis. Possible or not? Very well possible, which can result in enlargement of liver and spleen. Possible or not? Yes, it is possible. And along with the plasma cells, you're also having eosinophilic acellular deposits, which very well can be the amyloid, right? And the other features like anemia, serum creatinine is raised. So these could be, manifestations of the CRAB features. Okay. So this is definitely a multiple myeloma, which has probably evolved into an amyloidosis. See, what my children should know is, if I look at that NEET PG 2024, when I look at the, the morning session and the afternoon session, I'm seeing some topics being repeated. multiple myeloma, there was one question in the morning session, one question in the afternoon session, but the way in which the question was framed was different. So I want all my children to be thorough with the previous year topics. As I said, the exact repeat question may not come, but the topics are very, very important, which is why these recall videos are very, very important. Okay, right. Now coming to the next question. Coming to the next question. Which drug used for the treatment of multiple myeloma causes reactivation of herpes zoster? Well, there are various drugs used in the treatment of multiple myeloma, and most of them can, decrease your immunity. And whenever your immunity is suppressed, there is always a chance of reactivation of infections like herpes zoster. But specifically, and more commonly, can you tell me this reactivation of herpes zoster is associated with which drug used in multiple myeloma? It is the proteasome inhibitor, that is bortezomib. It is the proteasome inhibitor which is bortezomib. That is what you have to understand. Okay, that is the answer. Now coming to the endocrinology is over, and also the hematology part is also over. Now only one question was asked from the rheumatology part, and that was asked for the NEET PG set 1, the morning session. Only one question came from rheumatology, and let us go through the question. A 45-year-old man presents with fatigue and hemoptysis. His hemoglobin has dropped from 14 gram per deciliter to 8 gram per deciliter. So what does that mean? There is definitely anemia, but more importantly, it is an abrupt drop. It is a rapid drop of hemoglobin, right? Okay. And what could be the cause of the hemoglobin drop? Maybe related to hemoptysis. You can see that bronchoalveolar lavage shows a reddish fluid, which means there is some sort of a pulmonary hemorrhage, maybe due to some sort of pulmonary capillaritis. There is pulmonary hemorrhage. That is what has happened. There is pulmonary hemorrhage. And the patient serum creatinine is 2.3 milligram per deciliter. So there is renal involvement as well. So when you get a pulmonary involvement and a renal involvement, what do you call it? It is called a pulmonary renal syndrome. It is called a pulmonary renal syndrome. So if you have attended my offline class or online class, there is something that I always tell you. When you have a pulmonary renal syndrome, though there are many diseases that can produce pulmonary renal syndrome, I want you to remember 3 important disorders. Can you give me in the comment section what are those 3 important disorders that you should think? The list is actually big. There are many disorders, but the 3 most important disorders, can you tell me? Number 1, Goodpasture syndrome, then microscopic polyangiitis, and then Wegener's granulomatosis. Okay. Now, how to differentiate? When you get a pulmonary renal syndrome with a C-ANCA positivity, you are thinking about the diagnosis of Wegener's granulomatosis. When you have a pulmonary renal syndrome with P-ANCA positivity, you are thinking about a diagnosis of microscopic polyangiitis. Okay. When you have uh, ANCA negative, it could be Goodpasture syndrome. Correct or not? Goodpasture syndrome. Now here, what is positive? It is P-ANCA positive. And not only that, there is a necrotizing vasculitis with paucity of immune complex. So it is not an immune complex mediated vasculitis. So Goodpasture is out. Goodpasture, ANCA is negative, and also, there is immune complex, that is out. No granuloma. In Wegener's, you will have granuloma, that is out. And Wegener's, it is usually C-ANCA. Idiopathic pulmonary fibrosis is not going to produce any sort of pulmonary hemorrhage. Commonly, it's going to be a chronic cough, dyspnea on exertion, restrictive pattern. That is what is going to happen here. So the answer for this question is going to be microscopic polyangiitis. Option A is going to be the answer. So in this particular video, we have covered 3 systems. So I hope you have been benefited by this discussion. I'll be soon doing the next and the last discussion as well on the remaining systems like pulmonology, infectious diseases, that is going to be coming up next. So you can stay tuned. I'll let you know when is the date for the next discussion. So thank you so much, everyone, for joining. Dr. Fatima, Dr. Nafrin, Dr. Pratyusha, Dr. Angela. So thank you so much, everyone, for joining. And I hope that this discussion in a system-wise manner has been helpful for you, because as we, as we learn for the exam, the NEET PG exam, it is when we have a understanding on, okay, these are the more high yield systems, these are the topics that are being asked. It gives us a better perspective, and it is definitely going to help you for the exam as well. Okay, so thank you so much, everyone, for joining, and stay tuned for the next and the last session. Thank you so much.